it has a sodium. See, in vomiting, what is lost? HCl. And when HCl is lost, we need to provide chloride-rich fluid. And therefore, in Isolyte G, chloride is 150 milliequivalent. Against that, sodium is how much? It is 65 milliequivalent. In normal saline, how much sodium is there? 154 milliequivalent. So, chloride content is identical to that of the normal saline, but then sodium content is very low. It has a potassium. There is one point is missing. It is 17 milliequivalent, not 170. And then there is ammonia. See, ammonia gets converted into H ion by liver. Okay, ammonia gets converted into H ion liver, and therefore Isolyte G provides H ion, and H ion corrects what? Metabolic alkalosis. Amongst readily available fluid, only fluid which directly correct metabolic alkalosis by providing H ion is none other than Isolyte G. Okay, potassium is how much? 17 milliequivalent. Okay, now what are the indication and what are the contraindication? Answer is that as it provides all content lost in vomiting. In vomiting, it's useful and correct metabolic alkalosis. So indication are vomiting and metabolic alkalosis. And then contraindication as per considering content is that it contains ammonium chloride, which needs to be converted in H ion by liver. But if there is severe liver failure, then conversion may not be possible. As a conversion not થાય ને ammonia વધે તો શું તકલીફ થાય? Yes, it may aggravate, may precipitate hepatic encephalopathy, and therefore it should not be given. It is high in potassium. કેટલું છે potassium Isolyte G માં? 17 milliequivalent, and therefore the patient who is vomiting with shock, oliguria, renal failure, we have to be careful. And it provides H ion, and therefore should not be given in diarrhea. કેમ diarrhea માં શું વાંધો આપવામાં? Diarrhea causes what? It causes metabolic acidosis. H ion apo, so metabolic acidosis may get aggravated and therefore should not be given. Maintenance IV fluid, Isolyte M, richest source of potassium, but poor in sodium. Okay, how much sodium? 40 milliequivalent. How much potassium? 35 milliequivalent. Acetate gets converted into bicarbonate, also corrects by metabolic acidosis, contains phosphate, contains dextrose, and therefore good, reasonably good maintenance IV fluid for adults. Okay, now where do we use Isolyte M? Answer is that for correction of the hypokalemia. Why we want to give it for hypokalemia? How much potassium does it contain? 35. Okay, and ideal for maintenance because provides sodium, provides potassium, provides bicarbonate, provides phosphorus, provides calories. So good. And contraindication is that it should not be given in hyponatremia because how much is the sodium? How much is the sodium? Sodium is poor. That is only it is 40 milliequivalent. Okay, and because of its poor sodium content, it should not be given with hyponatremia, not effective in hypotension and shock. And because of the high potassium in renal failure, hyperkalemia, oliguria, shock, not a right kind of thing. Anybody from pediatrics? Yes, very few, at least two or three people are there. See, Isolyte P, when we were student, pediatric patient, we have to start with Isolyte P because it provides everything. Sodium 25 milliequivalent, chloride, potassium, acetate, phosphate, magnesium, glucose, everything. And therefore, when we were student, everybody was using Isolyte M as a maintenance fluid in children. But do you agree? Answer is that nowadays it is almost banned. It is banned because it's dangerous maintenance IV fluid. It's very hypotonic and carries risk. Say initially for about half a century, it was a routine practice to use as a maintenance fluid. But because of the hypotonic nature, high risk of the hyponatremia, and therefore almost abandoned as a maintenance fluid in children. But useful where? useful in treatment of hypernatremia. Okay, where we need to provide more fluid. Now, with this basic, we will end basics of IV fluid. But then, suppose if we want to give IV fluid and we want to calculate, how do you calculate? See, we should calculate with the calculator. Suppose if I say that I have routine IV set, and in 1 liter, say 12 hours, I want to provide 1 liter, then immediately, because mobile is with calculator, and therefore we calculate. Okay, but then is there any method? Answer is that we have a magic formula. Very simple, very simple. When you want to calculate for day, just use rule of 10. And when you want to calculate for hour, use rule of 4. So what is this rule of 10 and rule of 4? Answer is that rule of 10 is for routine IV set for calculating in 24 hours. How simple it is? It's unbelievably simple. Fluid in liter multiplied by 10 is equal to drop rate per minute. 1 liter આપવું છે ને તો 10 ટીપા રાખો, 2 liter તો કે 20 ટીપા રાખો, 3 તો કે 30 ટીપા રાખો. પૂરું, કઈ ગણવાનું જ નથી. અચ્છા, 2.5 liter આપવું છે ને તો 25 ટીપા રાખો. અચ્છા, ગુજરાતી કેટલાને નથી આવડતું? ચાલો, બધાને આવડે. અચ્છા, ઓ મેની. ઓકે, ફાઇન. Then I won't speak Gujarati much. Otherwise, some of the things which I convey in Gujarati immediately reaches to mind. So, very simple. If I want to say give 1 liter in 12 hours means 2 liters, so I will keep 20 drops. Now, some of the students are very bright. They will say that, sir, we have calculated, and instead of 1000 ml, this method provides 960 ml of fluid and therefore is not perfect. So currently available methods of calculating are what? ભગવાન ભરોસે ને સ્ટાફ ભરોસે. પાઇપ થોડો ધીરો આપજો. અરે પણ ધીરો એટલે શું? And our staff is also so good કે ધીરે એટલે શું એ પૂછે નહીં. અચ્છા, એન્ટીબાયોટિક 96% perfect sensitive હોય એવી કઈ છે? None. In that case, this is 96% perfect. The beauty of rule of 10 is what? When you start the sentence કે ભાઈ મારે 1.5 liter આપવું છે, સિસ્ટર 15 ટીપા રાખો. Same sentence, you can calculate volume to drop rate is the beauty of rule of 10. So if you want to give 1 liter in 6 hours, તો કે 40 ટીપા રાખો. 1 liter in 8 hours means 30 drops per minute. It's so simple. Two group, my pediatrician friend and my anesthetist friend, they don't like rule of 10. સાહેબ અમારે કઈ 24 કલાકમાં ના હોય, અમારે તો 1 કલાકમાં હોય. તો કે ચાલો, તો એ લોકો માટે rule of 4. Okay, rule of 4 is 100%. There is no complaint. And it's also equally simple that volume to be delivered in hour. 1 કલાકમાં તો આપણે કેટલા? તો કે 100 ml હોય, 200 ml હોય, 300 ml હોય. એવું તો ના હોય ને કે ભાઈ 1 કલાકમાં તો કે 2 liter, 3 liter, 4 liter. એટલે always for rule, when we calculate for 1 hour, it's going to be volume in ml divided by 4. And that will give you the volume. 100 ml, it's 25 drops, 200 ml, 50 drops. If you want to give 500 ml, then keep 125 drops. So it is something which is very, very simple. And when it comes to micro drip IV set, it is simplest of all. You need not calculate. I want to give 50 ml, I will keep 50 microdrops. I want to give 70 ml, sister keep 70 microdrops. So it is easy. And this rule of 10 or rule of 4 for routine IV set and volume is equal to microdrop for micro drip IV set is perfect, provided IV sets are fairly standardized. With this part, let us go to clinic. Let us go to hospital and try to find out that for different kind of medical disorder, how do we select one fluid over other? Vomiting is a common problem. Loss of HCl, loss of potassium, and loss of water. So hypokalemic, hypochloremic, metabolic alkalosis with fluid deficit. Now, important to remember that I will skip the slide. ક્વેશ્ચન આન્સરમાં એક પોઈન્ટ લેવા માટે આપણે ઘણો બધો સમય આપ્યો આજે, એટલે થોડુંક હું આઈ હેવ ટુ રન ઓવર, કારણ કે સ્લાઇડો ખૂબ બધી છે. In vomiting, how do we select the fluid? Answer is that we have two fluids as a right choice. One is isotonic saline with oral potassium supplementation, or with severe hypokalemia, potassium in pint, and second is Isolyte G. Okay. Now, most common say Isolyte G we don't use routinely, but when we provide potassium, it is fine. And oral potassium supplementation is fairly safe, because when we give a fruit juice, then it will have it's gastric friendly and may serve the purpose. Now, how saline? See how saline takes care of all problem which occurs because of vomiting, because ammonium chloride get converted into H ion. That is the benefit of Isolyte G, which we have seen. But how saline is effective? Answer is that it provides adequate volume. So kidney takes care of rest of the part. Adequate fluid, adequate sodium, adequate chloride, adequate perfusion. So bicarb, which is extra, will get excreted, and metabolic alkalosis will corrected. Hypochloremia, because how much chloride normal saline contains? Loudly, 154 milliequivalent, because sodium and chloride are same. If sodium is 154 milliequivalent, chloride will also same, and therefore it will correct hypochloremia. It will prevent further loss of potassium, and therefore we need to provide potassium along with this. So this is something which is very simple. Isotonic saline with KCl, Isolyte G in selective patient who don't have jaundice, don't have renal failure, shock, oliguria, or hyperkalemia. Now, one part which often not discussed in most of the textbook, that suppose if we want to go for cold water stomach irrigation, then which fluid will you use? Answer is that અમે સ્ટુડન્ટ હતા ત્યારે તો અમે cold ice water વાપરતા, but then that was a wrong concept, because when we go for gastric irrigation, patient will have vomiting along with some of GI problem, and when simple water is instilled in the stomach, and when it is removed, it is going to remove even electrolytes, and that's going to be harmful. And therefore, in patient who is hemodynamically unstable, patient has hyponatremia, patient has hypokalemia, patient is having low BP, it's not wise decision. Use normal saline for gastric irrigation. તો કે સાહેબ normal saline કઈ મફત નથી આવતું. તો પછી આપણે એમ કરો, cold water છે ને એમાં મીઠું નાખી હલાવી અને use it for the same. એમાં cost નહીં લાગે. So this is something which is very basic, especially in sick patient with electrolyte disorder. Don't use pure cold water. Use cold water with salt. Okay, diarrhea. Two important characteristics: rich in potassium and rich in bicarbonate. Because it is rich in potassium, it will cause hypokalemia. Rich in bicarbonate, so it will cause loss of bicarbonate rich fluid, will lead to what? Metabolic acidosis. So patient will have hypokalemic, hyperchloremic, metabolic acidosis with fluid deficit. The best way to treat is to give ORS. Very important. While instructing for ORS, સાહેબ અમે ઓલું તમે પડીકું આપ્યું ને એમાંથી એક એક ચમચી પાણીના ગ્લાસમાં નાખી હલાવીને આપીએ છીએ. No, that's a wrong method. We should say that 1 literની બોટલ લઈ લો. In 1 liter bottle, add full packet of ORS, shake it properly, and then use it, because composition of ORS is vital for its proper absorption, and therefore use it accordingly. When we don't have, we cannot provide adequate ORS, diarrhea is severe, patient is hemodynamically unstable, we want to give IV fluid, then IV fluid of choice is Ringer's lactate. Okay, so very, very important. And then potassium patient may require, considering what is the potassium status. So to summarize, if patient has vomiting, which fluid will you give? Loudly. If diarrhea, this is basic, but I have seen that mistake even in primary selection. Without, if we don't have even electrolytes, this is what will be the turned out to be right for your patient and should be kept as a basic understanding of the problem. Now, as a nephrologist, 1 or 2 slides on fluid therapy in renal failure. Fluid therapy is what? Don't give, don't give, don't give. IV fluid only if mandatory. Optimum IV fluid to avoid overload. Restrict sodium, restrict potassium. Provide adequate calories. Avoid isolytes because rich in potassium. Avoid saline and RL because they are rich in sodium, may aggravate hypertension, may aggravate anasarca, which is present in large number of patients. Plan it properly. And with this, I think that I don't want to discuss much about fluid in renal failure because by and large it should be avoided. In patients with hepatic failure, potential imbalances. See, patients are likely to have vomiting. So there are chances of imbalances. Patient of cirrhosis may be on diuretics, so may land up with some of the pre-existing electrolyte disturbances. So hypovolemia, hypokalemia, vomiting linked to metabolic alkalosis, hyponatremia, and all of us know that hypoglycemia is something which is very, very important. So we need to see underlying problems should be addressed, and vomiting and use of diuretics are culprit. Hypokalemia needs very special consideration because if potassium is low, it will stimulate renal ammonia production, which can precipitate or aggravate loudly. Yes, hepatic encephalopathy, and therefore provide adequate potassium. So we feel sodium, we are not, see, when we see the patient of hepatic problem, we don't apply mind to calculate sodium. But it's important that patient may have vomiting, diuretics, and because of that pre-existing sodium loss. And moreover, maintenance requirements are required, and therefore provide adequate potassium, because without providing adequate potassium, your hypokalemia won't improve. Okay, and then adequate dextrose are required to prevent hypoglycemia, because hypoglycemia is common in presence of liver failure. Why hypoglycemia risk is more? Because of what? Loudly. Due to decreased ability of liver to store glycogen will decrease, and because of that chances of hypoglycemia is more. So give round the clock dextrose 25%, say 4 hourly or 6 hourly, or give infusion, say 20 ml per hour or so to prevent hypoglycemia. So nutshell, adequate dextrose, adequate sodium, adequate potassium are a key point while planning fluid therapy in patient with liver disorder. Now going to the last part of fluid therapy, and that's fluid resuscitation. See, now fluid resuscitation is something which is very, very important. There is changing trend in current concept. Okay, fluid resuscitation is a fundamental component of management of all acutely ill patients. With the time, the only constant thing in life is change. So wherever you go, whichever may be the field, the concept is changing. Everything is changing. And because of this change, even in fluid planning, there are some recent advances and recent changes. So proper administration of the fluid is going to be most rewarding. So plan perfect and proper therapy. Fluid therapy, fluid resuscitation is a hot topic. How fast, how much, which fluid, right dose, right time, and right fluid saves the life. So what is right time? The patient have a right time. ઘેરે હોય ત્યાં સુધી તો આપણે કઈ આપી ન શકીએ. ઓકે, તો કે એવું નથી. Right time is what? See, initial hours are very, very critical. Okay, so early adequate fluid replacement is required, and that is going to be rewarding. So what is right time? Answer is that it is initial first 3 hours. Okay, this 3 hours is important. Now, why initial 3 hours right time is important? Because longer the delay, microcirculatory hypoperfusion carries risk of organ damage, and then subsequently once organ is damaged, we are end up in trouble. So a right time, and then comes the right dose. That how much fluid should be given? Answer is that at least 30 ml per kg of IV crystalloid is by and large required. See, it's not always by and large. If patient is edematous, grossly, then we may have to change it. But in general, if there is no specific thing, what are going to give? 30 ml per kg of IV crystalloid fluid. It's a 30 ml per kg means 60 kg weight hoy to ketlo apso? How much? Loudly. 1 liter and 800 ml. Ketle kalakma? 3 hours. Why? Because we all are scared. See, we provide fluid to ke, sister 100 ml રાખો ને. અરે પણ 100 ml 24 કલાકમાં 2400 ml જશે તો initial hours are lost. And therefore, if there is no contraindication, see to it that minimum more than 500 ml, say 600 ml, 700 ml is infused, considering volume considering weight of the patient. Okay, and then this is something which is important. Additional fluid guided by frequent hemodynamic reassessment. And how much should be the blood pressure? Mean arterial pressure should be 65. Okay, mean arterial हमारी पास एक monitoring नहीं कि हमें mean arterial pressure calculate થાય. Okay, we have BP instrument. So how do we calculate? Answer is that systolic blood pressure plus 2 multiplied by diastolic blood pressure divided by 3 will be mean arterial pressure. And how much mean arterial pressure is currently recommended? 65. Okay, and then comes the right fluid. Okay, that what kind of fluid should be given. Now, there are multiple choice of fluid with us, and therefore we have to go for the right kind of fluid. Select right fluid. What is right fluid? Answer is that the fluid should be properly determined so that it effectively increases intravascular volume. But ideal fluid does not exist. Different fluids have different indication and contraindication. And therefore, when we determine, we try to select fluid, we need to know basic physiology. That what is the physiological basis? Number 1, we should give crystalloid or colloid. Number 2. Number 3, when we decide to give crystalloid, so should we give saline or should we give balanced fluid? And suppose in those patients where we think that yes, we would like to give balanced fluid, then which balanced fluid? Ringer's lactate or newer fluid like Isolyte? So right decision is something which is very important. So we start with the physiological basis. Now, which fluid to use? 5% dextrose, crystalloid, ke colloid? Okay, chalo. Let us see physiological basis. કે ભાઈ ક્યુ આપશું? તો કે the fluid which expands intravascular compartment is the fluid which is good for us. Okay, now suppose we give 5% dextrose, then what will be the expansion? Answer is that out of 1 liter only 83 ml will be expanded. And therefore, if by chance આપણે પાઇન્ટ ચાલુ કરી દેજો તો સાહેબ પાઇન્ટ ચાલુ કરી દો 1 લિટર આપ્યું કઈ બીપી વધ્યું નથી. ફિઝિશિયન may think તો સાહેબ કે સેપ્ટિસિમિયા હશે. મોદી સાહેબ વયા ગયા, but surgeon may think that oh, it could be some internal bleed, but it may be improper selection of IV fluid. Do you know which is the most widely fluid in day-to-day practice? It's Isolyte G. જે હાથમાં આવે બાટલો ચડાવી દો. એટલે જો બાટલો ચડાવી દો એમાં 5% ચડાવી દીધો તો બીપી વધશે નહીં. See, first is my friends sitting here. All over they will listen partly, and partly they will try to understand what is going on. So when 5% dextrose is given, it's ineffective because its ability to expand intravascular compartment is only 83 ml. This fluid is distributed in all compartments equally. Against that, the isotonic saline, ringus lactate, balanced fluid are preferred because it's sodium-rich fluid. Sodium is distributed only in ECF, and therefore sodium-containing fluid will be distributed only in ECF compartment, and therefore 1 liter fluid will expand a total 100 ml, 100% of ECF, and expansion of the intravascular compartment will be as high as 300 ml. And because of this reason, the crystalloid is fairly effective. But in operation theater, whenever a patient develops severe hypovolemia and we don't have any way out, that's the time we use colloid or blood product because they remain entirely in intravascular compartment. Not only that, the concentrated form of hypertonic solution like 25% albumin will shift fluid from other compartment to intravascular compartment and will increase the volume even greater than what is infused, and therefore most effective. What is most effective? Colloids. Okay, blood products, they are most effective. Now, this is again summary that 10% remains dextrose, crystalloids, sodium containing is 25% or 30%, and colloid is 100%. Okay, so considering this part that dextrose is ineffective, saline is very good, and colloid is best, the question arises that whenever you see patient, keep your eyes open and provide right kind of fluid. RL and saline are preferred. Colloid and blood are most effective. Never use 5% dextrose or isolite. 5% we don't use for 2 reasons: ineffective expansion, and moreover, when there is hypovolemia, there is associated sodium loss. And because of that, when 5% dextrose is used as a replacement solution, it's going to precipitate hyponatremia. Isolites are no good because they are poor in sodium and rich in potassium. Okay, and therefore so is the half normal saline because it won't be as effective as normal saline or ringus. Achha, now instead of saline, can we use dextrose saline? Because we want to provide sodium, it contains sodium, but some of the patient also requires some calories. So dextrose saline will serve the both purpose. So is it wise to use dextrose saline instead of normal saline for resuscitation? Answer is no. Why? Because rapid administration of dextrose containing fluid, even in non-diabetic, will lead to hyperglycemia, osmotic diuresis, urine output will increase, and our aim is to provide adequate fluid. But if urine output is good, we will have 2 disadvantages. Number 1, that with good urine output, we will feel, oh, sir, madam, output is good. Slow down rate of infusion because it reflects adequate perfusion. So we are misguided. And second thing, increased urine output means already deficit patient will be more penalized, and therefore avoid all dextrose containing IV fluid for initial fast resuscitation. I'm not going to talk about giving dextrose saline in 4 hours or 6 hours. No, it's not about it. It's giving 30 ml per kg body weight in first 3 hours. Okay. So avoid all dextrose containing fluid, and for rapid infusion, RL and saline are the prime. Now comes the question that crystalloid versus colloid. Now, it's a great debate. I have 4 players who is going to run this marathon today. And I request all of you to select 1 player. That at the end, one will be final winner, and whether you are betting for the same or not is the question. So please select 1 out of them, and then let us see who runs fast today. Okay. Now, first, crystalloid over colloid. See, there is nothing to be discussed because we have already discussed that crystalloid is good, but colloid is okay. Colloid is better. See, Why colloid is better? Because volume expansion with colloid is greater, faster, and longer. So question does not arises whether crystalloid is superior or colloid. But that's not the case. It's the only efficiency. But what is the safety? What is the adverse effect? And what are the outcome effect? What data says? So it's not only efficiency. In war, you must have seen that our one of the bright soldier had with inferior aircraft the best kind of USA made aircraft was broken. So it's all about how you use it. So let us review the literature. Literature will be albumin versus crystalloid, hydroxyethyl starch versus crystalloid, and colloid versus crystalloid as a whole. Now, albumin, very, very important, very useful, whether it cures or kills. Now, there are studies, SAFE study, Albio study. This whole study says that at the end, if you look at the outcome at 28 days are same in both the studies. There is no difference in mortality at 28 days or at 90 days. So currently, recommendation is that it cannot endorse the use of albumin in light of its expense and current lack of proven benefits. So should we start with albumin? Answer is no. Is it the first choice? Answer is no. We suggest, say, what Surviving Sepsis Guidelines 2021, recent guideline says, we suggest use of albumin in septic patient who received large volume of crystalloid. So this Surviving Sepsis Guidelines and most of the study says that use albumin as a second line, as a adjuvant to crystalloid and not as a primary one. So albumin should be considered as a second line agent indicated in patient with unresponsive to crystalloid who cannot tolerate large volume of crystalloid. So either give crystalloid or give crystalloid and don't give albumin alone. So this is what is the recommendation. Amongst colloids, albumin is superior, safer, better than hydroxyethyl starch. Albumin cures, but it kills the pocket. It is 50 times more expensive than normal saline, and therefore use it selectively. Now, hydroxyethyl starch versus crystalloid. What are the changing trend? See, there are multiple trials, okay? But in 2013, European guidelines says that it's harmful in AKI and carries high mortality in different studies. So in 2013, it was recommended to avoid in sepsis, burns, or critically ill patient and use it at lowest dose for shortest period. But so it was irrationally used all throughout, and therefore subsequent data says that unrestricted irrational dose has led to unacceptable high adverse effects. So breaking news in 2018 was what? That in January 2018, it was banned. It was banned from the market. And then subsequently, people said that no, it's whether it's the end of the story, answer is that no. People protested that, say, killing cow to get rid of ticks is not proper. We see, this is the title which was given, and therefore make more strict rules. Okay, it helps in post-operative patient and found to be better for renal function or survival when used judiciously. So in major operation, it may be harmful, but when used, it is used very properly, it may be helpful. And therefore, what is the current advice? Current advice is that use in OT, use for surgical patient, use to replace blood loss, but avoid in ICU. Used selectively in surgical patient, avoid in ICU, like sepsis, renal replacement therapy, burns, many patients. So medical ICU, there is no role of hydroxyethyl starch. When we are in crisis, in surgical line, in operation theater, use it judiciously. And therefore, in 2018, subsequent recommendation was that strictly avoid in sepsis, burns, critically ill patient, kidney injury, and mortality are the problem. Use for acute blood loss, use judiciously, don't use as a maintenance thing. And very important, that dose should be less than 30 ml per kg. And day one only on day one, not subsequently. And then subsequently follow up renal status is the guideline. Okay. Now, finally, overall colloid and crystalloid. What are the guidelines? Say, many guidelines. Out of that, I'm not going to discuss much, but then Cochrane review said that crystalloid is preferred over colloid. Anesthesia journal said the same thing. European guidelines says the same thing. And surviving sepsis guidelines 2021, they said that we recommend using crystalloid as first-line therapy for resuscitation. So crystalloid is the primary fluid for resuscitation in non-septic as well as septic patient. No indication currently exists for the routine use and use of the colloid as a first line over colloid in day-to-day practice. So colloid is potent, used selectively. Benefits are there. Shorten the time to achieve hemodynamic goals, but increases the expenses. More effective than crystalloid. Stay in intravascular compartment for the longer time. Most effective, so will help to bring the blood pressure fast. So if you have given crystalloid and blood pressure is not improving, then in selected patient you may give albumin along with the same. So there are benefits, but by and large, we need to see that crystalloid is preferable to colloid in fluid resuscitation. Uses colloid in few hemodynamically unstable septic patient where large fluid volume is required. So take-home message is that crystalloid is in and colloid is out. Chalo. Out of 4, 2 are out of race. Okay. So marathon at 16 kilometers, we have only now 2 players. And that is, we have saline versus balanced fluid. So the question arises that battle between the best. Which one will you use? Okay. Because both are good. And there is a lot of discussion, lot of papers, lot of research, lot of controversy. So let us analyze it, that why there is controversy. If one is good and one is not good, there won't be controversy. So first, what is the difference in composition? See, why saline is not normal? See, we say that it's normal saline. But why saline is not normal? Answer is that high chloride. How much is the chloride? How much is the chloride? And normal serum chloride? 100. Are both matching? Okay. So, and second thing, that pH is low. Osmolality is okay. So, it is a supraphysiological chloride. And does it contain buffer? No. Does it provide bicarbonate? No. So, saline is not physiologically normal. And in some of the literature, they said that abnormal saline. They say abnormal saline. Okay. So when you compare, the balanced crystalloid are more physiological. How much is the chloride in RL? Loudly. 109. How much is the sodium in RL? 130. So, and then pH is also matching. RL pH is 6.5, and therefore composition is more balanced. Okay. Now, clinical effect of different composition. Say, RL, we have nothing to discuss because it matches with the ECF composition. But normal saline is considered to be harmful. Why? Answer is that the chloride is 50% higher in normal saline than plasma, which leads to hyperchloremia. And this hyperchloremia is dangerous for two major reasons. Number one, carries risk of AKI. Number two, carries risk of hyperchloremic metabolic acidosis. Now, why AKI occurs? Answer is that when the chloride is high, this chloride in tubule will have effect on tubuloglomerular feedback. It will lead to efferent arteriolar vasoconstriction. So the blood supply which is provided to glomerulus will be affected, and with that there will be decreased GFR, decreased urine output, and risk of AKI. ચાલો આ તો બધી થિયરી વાત થઈ. What is the evidence? What is the evidence? There are different rounds of fight between saline and RL, balanced fluid. So the first round is that normal saline is better. Now, what are the, how normal saline is better? What are the evidences? Number one, that normal saline is #1 fluid used worldwide. More than 200 million liters of saline is used annually only in USA. Normal saline used as a default crystalloid of choice. બધાને ખબર હોય, પેશન્ટ આવે એટલે સિસ્ટરે નોર્મલ સલાઈન ચડાવી દે ઇમરજન્સીમાં, અને આપણને ખબર હોય કે નોર્મલ સલાઈન જ અપાય. It's preferable because easily available, low cost, compatible with blood, rational for using. અમે તો સલાઈન જ વાપરીએ છો. It's how what we have been always doing. Everyone is doing the same thing. Even in training, we were using normal saline. Nurses starts it automatically. But these are not evidences. These are not evidences. There is no paper which tells us that comparative study of normal saline and Ringer's lactate, the normal saline showed decreased mortality, decreased need of ventilation, decreased risk of AKI. No such evidences are available. So saline is better than balanced fluid. What are the evidences? None. If anybody has ever read any paper, please guide me. Please inform me. At least I haven't. So the questions round second. Round second is what? Balanced fluid is better. Do we have any evidence? Answer is that long list. I won't discuss because there are many. Evidences, papers are many, articles are many, literature is many. And therefore, I cannot discuss everything. But very important recent trial in 2018, USA based SMART trial and SALT-ED trial. They are the major trial which have analyzed and said that SMART trial said of 15,000 patients that lower rate of death, renal replacement therapy, and persistent renal dysfunction with balanced fluid, and therefore it is better than normal saline. This is the major. I mean, if somebody ever says that which is the main current trial which favors balanced fluid, answer is that it is SMART trial. It should be provided preferentially to saline in most critically ill patient. This is what is the one of the articles said. And same author in January 2022 has come out with exactly same conclusion. But in this 2022 article, it was a systemic analysis and review of all the studies. So final of the final information says that balanced fluid is better than Ringer's lactate. What surviving sepsis guideline says? In 2017 surviving sepsis guideline, it was said that normal saline and balanced fluid are used. But what 2021 guideline says, they say that for resuscitation in sepsis, we suggest using balanced crystalloid instead of normal saline. So, with all this data, we said that this is better. This is for albumin, which we are not really going to discuss. So when we discuss about normal saline, chloride-rich fluid prescribed in vast excess to physiological fluid has no clinical benefit, no physiological benefit. See, in India, the cost between normal saline and that of Ringer's lactate, or even for that, if we say Isolyte, is not really that big. And chloride containing normal saline can be harmful. So, IV saline is harmful. Ban kar deso? See, we have evidences, so many evidences, including 2021 and 22. But still, all of you are not agreeing to ban it. Chalo, I did this thing. See, I have studied everything and said that it's a demise of normal saline. No, that's not the case. Saline is not dead yet. Is Ringer's lactate perfect for all? No. Cannot be given with blood product. Not suitable for metabolic alkalosis. Not good for persistent vomiting. Not good for hypochloremia. For neurosurgical patient, it is not good. And at that time, what we need is the normal saline. So for vomiting, normal saline is the choice. Hypochloremia, normal saline is the choice. Metabolic alkalosis, normal saline is the choice. Hypovolemic hyponatremia, normal saline is the choice. Diabetic ketoacidosis, brain injury with blood. So normal saline is not that. IV saline, not too much, not too quick, only to healthy kidney is something which is quite safe. So every fluid has its own advantages. Moreover, what are the evidences which help us to continue normal saline? Answer is that in 2015, split randomized trial, use of buffer crystalloid compared with saline did not reduce risk of AKI. Okay? Sahib, juni baat karo cho. Saru. Then basic trial 2021. Use of buffers fluid compared with saline did not reduce 90 days mortality. Any other additional evidences? Any JM 2022 plus trial. They said that use of plasma light compared with saline did not reduce 90% mortality. And therefore, take-home message is that normal saline may be harmful, but should be used judiciously, should not be banned. NS and RL both are effective IV fluid. We need to select right fluid for the right patient. If patient presents to us with vomiting and metabolic alkalosis, what will you give? Loudly. Okay? So that is what is the thing. Now, with two more discussion, I will end, three more discussion, I will end my story about fluid. Ringer's lactate myths and facts. Ringer's lactate should be avoided in hyperkalemia. Does it contain potassium? Yes or no? So do you agree with me that we should avoid, or you don't agree? Jawab sarkho no aigo. Okay? See, RL has potassium versus normal saline has no potassium. Okay? So avoid RL, which is potassium containing, and select potassium-free normal saline is a wrong concept. Is a wrong concept. So question arises that why? Why to prefer RL and why to avoid NS in patient with hyperkalemia? The reason of choosing is that RL will not increase serum potassium. Sir, it contains potassium. But how much potassium does it contain? 4 milliequivalent. Now, if patient has potassium of 6.5, and we are adding potassium containing fluid with 4 milliequivalent, whether from 6.5 it will become 7 or from 6.5 it will become lesser. There is a water in hot water. There is a one bucket with temperature of 60-degree temperature, and second bucket with water of 40-degree temperature. Now I have added 40-degree temperature bucket to bucket which has 60-degree temperature. Then what do you think will be temperature from 60 will jump to 65, 70, or from 60 it will reduce to 55? Whatever amount of RL you provide, it has a lesser concentration of potassium, which can never increase the potassium level. With dilution, it will decrease. That's number one thing. So it pulls the potassium towards 4.4 milliequivalent and does not push more than 6.6 or 6.5, whatever it may be. RL cannot increase potassium. It's like mixing hot and less hot water. Okay? And second thing, NS has potential risk of worsening hyperkalemia. Sir, NS does not have potassium. Do you remember it? Answer is that yes. But understand the effect of NS and RL on acid-base physiology. See, when there is metabolic acidosis, the acidosis will push potassium out. Okay? And therefore, when large amount of sodium is given, it will push the potassium out. Against that, when RL is given, which will have metabolic alkalosis effect, will correct acidosis and will shift potassium inside the cell. Okay? So this is what we have already discussed, that potassium-free NS is safe, is a myth. Rapid infusion of saline will cause the hyperkalemia, will aggravate the acidosis and will cause hyperkalemia because of the shift of potassium. And therefore, what we have is that potassium shift have a greater effect on serum potassium than actual potassium concentration of IV fluid. So in hyperkalemia, RL plasma light should be avoided, is a myth. In vivo, Ringer's lactate and Cabilite lowers potassium. Superior, safer, preferable to abnormal, normal saline in hyperkalemia. अच्छा चलो ये बात पूरी थी. But now second thing, that it has lactate. See, I have a problem in using Ringer's lactate because it has a lactate, and therefore in my patient lactate level is high, so it's going to aggravate lactic acidosis. So I am reluctant to use Ringer's lactate. But then here my vice friends are present who will help me to understand the concept. RL causes lactic acidosis is a myth. Why? Remember and understand the term lactate and lactic acid. They are not interchangeable. It's a common mistake. Difference between lactic acid and lactate in RL is essential, very exciting and interesting. We will have something basic. Anion plus cation. If in chloride we add H, then what will happen? Chloride plus H ion. Loudly. HCl. Acidic or not? Now in chloride I have added sodium. So what will happen? NaCl, salt. Equally acidic, like hydrochloric acid. Yes or no? No. So chloride is anion in both, but its physical characteristic will determined by presence of associated cation. When cation is H, is strong acid. When cation is sodium, it's almost neutral. Likewise, lactate in Ringer's lactate is a sodium lactate. Okay, so lactate is an anion in both lactic acid as well as in Ringer's lactate. But anion lactate plus cation H is lactic acid. Anion lactate plus cation Na is a sodium lactate which is present in RL. Okay, so when H ion is added and lactic acid is prepared, pH will be what? How much? pH will be severely acidic. While sodium lactate has pH of what? 6 to 7.3. It's alkaline or is acidic? Alkaline. Why all of you are so quiet? Are you not agreeing with me? But this concept you have not heard any time. So lactic acid is lactate plus H ion, which is acidic, harmful. We are scared of it. Ringer's lactate contains sodium lactate, which is alkaline, provides bicarb, does not have acidic effect. And therefore, when you provide RL to patient, it's not going to aggravate your lactic acidosis. साहब lactate तो वधे ने तो क्या lactate बोले ने वधे, but sodium lactate is benign while lactic acid is harmful. What will happen when RL is infused in patient with lactic acidosis? Minimal increase in serum lactate level, no aggravation of lactic acidosis, no change in pH. Okay, so this is what is the basic thing. So now if patient has lactic acidosis, will you use RL or you won't use? It's safe. It's safe. But nobody teaches this thing. And that's the reason we are scared. Okay. Now, coming to the final of the final. Balanced solution. Newer balanced solution. Why RL is effective, then why there is need of newer solution? See, every fluid has its own limitation and own strength. When there is severe acidemia, there is inadequate hepatic metabolism of lactate. So production of bicarbonate from infused lactate in RL is impaired. So lactate cannot act as a bicarbonate source until circulation improves. So severe shock, BP not recordable. Ringer's lactate given won't be effective in correcting acidosis. Okay, and moreover, the lactate may marginally increase serum lactate level, although it won't aggravate lactic acidosis, but marginally lactate level will increase, and that may misguide. Lactate વધી ગયું છે. In liver transplant, liver disease, the conversion of lactate to bicarbonate may not be adequate. In oliguria, in high potassium patient, in renal failure patient, we may not prefer to give Ringer's lactate. Calcium is hypotonic nature as the problem. Newer fluid, plasma like Kebilite, what are the advantages? The advantages are that composition is most similar to ACF. Sodium 140, potassium 5, chloride 98, magnesium good for patient, especially in ICU patient. Contains acetate instead of lactate. So lactate problems are solved. Osmolality is 295. What is the osmolality of Ringer's lactate? So it is hypotonic, cannot be given to cerebral edema, neurosurgical patient, brain surgical patient. So, but this can be given, and pH is 7.4. So if you look at this composition, you will realize that as compared to NS, composition of RL is better. As compared to RL, the composition of plasma light is better. Okay. Now, if instead of lactate, acetate is there as a buffer, what is the advantage? Lactate gets metabolized only in liver. Acetate is metabolized across the body, hepatic and non-hepatic tissue. So conversion is not dependent on liver. Even in shock, the conversion of acetate to bicarbonate is preserved. So is in case of liver disease, sepsis, and other thing. Does not affect liver problem. And because of this, does not contain calcium, so can be given with blood product. Also provide magnesium, because we said that hypomagnesemia is common. So composition is more similar to plasma and therefore is safer, better buffering effect. So where it is useful? Useful in severe metabolic acidosis. Shock, BP is not recordable. Severe diabetic ketoacidosis, BP not recordable, and acidosis is severe and patient has electrolyte problem, neurosurgical patient, cardiac surgical patient, renal transplant patient, all this, this is very good. So from today onwards, should we start using plasma light, KB light instead of Ringer's lactate? Answer is no. Answer is absolutely no. This is the fluid which is very useful when it is used in very sick patients. So we are using this fluid very widely, especially in very sick diabetic ketoacidosis. It's very useful. Very recent trial has also supported. So in very sick patient, BP when it is very low, diabetic ketoacidosis, when you feel, oh, this patient does not likely to come out, in such patient, we don't use Ringer's lactate. We use this fluid. But otherwise, we use Ringer's lactate. So why I repeated? Because my friends should not go with take-home message that Dr. Sanjay Pandya said that stop Ringer's lactate and start KB light. No, that's not the case. Every fluid has its strength. So what is the trend in 2022 guidelines? Crystalloid is preferred over colloid. When it comes to selection of IV fluid, no fluid is better than other. Look at the history. Look at the electrolytes. Look at the acid-base disorder. Look at the patient's response. Acidotic patient, start with balanced fluid. Alkalotic patient, start with loudly normal saline. Resuscitation, by and large, when there is no other abnormality, start with Ringer's lactate. Normal saline is not the first fluid of choice. Use it selectively. There are indications like vomiting, hypochloremia, metabolic alkalosis, hypovolemic hyponatremia, and others with blood transfusion, with ceftriaxone, where NS is better. But by default, start with Ringer's lactate. Okay? And even if you start with normal saline, when you give up to 2 liters of fluid, this side effect, adverse effect is unlikely to occur. So if you are planning to give, say, 1 liter or 1.5 liters of fluid, don't bother, give anything. But if there is diarrhea, start with Ringer's lactate. If there is vomiting, start with NS. So judicious, right kind of use of fluid, considering underlying problem, is something which is very, very important. RL is indicated in majority, but plasma light is required in few. Very critical, very severely ill, acidotic, hypotensive, decay patient, severe jaundice, major brain, liver, cardiac transplant surgery, definitely better. Albumin, best as a second line, not as a first line. Very expensive. Used in hypoproteinemic septic patient, cirrhotic patient, unresponsive to IV crystalloid as a second line, along with the crystalloid. The patient who cannot tolerate large amount of fluid. Hydroxyethyl starch, used selectively. It's not contraindicated. It's not out of market. Avoid in medical ICU. Avoid in sepsis, burns, critical patient. Avoid in AKI patient. There is a risk of kidney injury and increased mortality in such patient. In surgical patient, to replace blood loss, give lowest dose, 30 ml per kg, and for shortest period, that is less than 24 hours. If you are keen to listen more, next week is APICOM, Association of Physicians of India conference at Jaipur, where I'm going to talk. I'm given oration, Siddharth Shah Memorial Oration, where I'm going to talk on hyponatremia, number 1. And number 2, we have 4 hours workshop on fluid and electrolytes. So if you think that in such a short time you have gained more, you are going to get more information even than this in this workshop. With this, I would like to thank all of you for using this book. And in the last, I would like to let you know about our educational activity. And we have website kidneyeducation.com. This website is globally leader and globally unique because it is in 40 languages, proud of India, received World Record Award, 200-page kidney book, not 2 pages, not 20 page, 200-page kidney book, Save Your Kidney, is available in 28 international and 12 Indian languages free. The website received 10 crore, 100 million hits in last 15 months. And provides free access to book, free to read, free to download, even free through WhatsApp. And it's not me, it's we, the team of nephrologists, more than 100 nephrologists across the world, including global leaders like President International Society of Nephrology, who prepared Italian version, President International Federation of Kidney Foundation, which is who prepared Spanish version. We are blessed. We are blessed, and very important part, that activity which we are running from last 16 years is not allowed to be supported by any pharmaceuticals. The website which received 10 crore hits is without advertisement. We take help of everyone, but we humbly refuses financial help of any time. This is our service to society. With this, we will end this fluid therapy talk. Thank you very much.